Really appreciative of the invitation. I was telling Miriam as we were planning this session how much I enjoy getting a chance to interact with people who have serious illness and their family members, because a lot of the work that I do is on a provincial scale in policy and planning development and things like that. So I don't always get to talk to, real people. So this is really a treat. So as I go through, I'd invite you to ask questions, and I'd rather have you interrupt than save it for later because someone else might have the same question. So if you want to text that through, and I'll ask Miriam and Amy to just interrupt me verbally if I don't notice in the chat, and we'll go through that way. So the title of this is Palliative Care in Parkinson's. We're doing okay. Why talk about palliative care now? So we're gonna go through some reasons why you might want to know something about palliative care, and there's a new term called palliative approach that I'll talk about a little bit. And we always find that the best time to talk about things that could happen in the future is before a crisis occurs, when you're still calm and things are just sort of ticking along. So often people will say, well, I don't want to talk about palliative. I don't want to go there right now. But then when things do get worse and things come up, it can be a much more difficult conversation. So that's kind of why we're talking about it early on. So this is my picture, and I'm actually kind of thankful that it's not live. I always feel a bit awkward when I can see my face talking to me. So my background is in home care nursing. I was a home care nurse in Vancouver in the Kerrisdale area and really enjoyed that work. I kind of got bit by the palliative care bug when I was working. I worked at UBC Hospital on a medical floor and just saw the difference when in those days it was there was a very distinct transition from when somebody was focused on cure and when they were focused on palliative. So what I noticed at that time is that when the focus changed to palliative care, the whole atmosphere around the patient and the family and the healthcare team just completely changed. The anxiety levels went down in general, and just really felt a really marked difference. And so that's what attracted me to palliative care. And I'll tell you some more about what I love about it as we go. But just a little bit about the Center for Palliative Care. So we've been around for 5 years now. We had grant funding that was for 5 years. So we're just in the middle of a review right now to see the next steps for the center. We work closely with the Ministry of Health in BC. We also work with a number of national committees and organizations as well. So our role is to promote best practices for healthcare professionals, as well as to support nonprofits and community organizations to support people to live well at home for as long as possible and to really promote that. So we have kind of two focuses of our center. The side that I work on is for clinicians. So my background is in nursing, but I do plan and coordinate education for all different disciplines within healthcare. So healthcare aides, dietitians, physicians, pharmacists, all of the different disciplines that work together to support people with life-limiting illness. And then the other side of our center is more publicly focused. So there's an initiative called Compassionate Communities, and we did a series of small grants to support hospice societies to do things like advanced care planning sessions, which we'll talk about a little bit, ways to develop a social network to support yourselves and your families and that kind of thing. So that's the other side of our center. So a little bit more about my background. I have been an educator for a long time. I was also a manager at BC Cancer and have worked on a number of projects. And the majority of my interest and projects have been focused on palliative care, on symptom management, on supporting people in a holistic way in terms of social supports and emotional and psychological, spiritual, all of those sorts of things. So I really like to look at the whole person as well as the whole care team. So I've done a number of projects helping different disciplines to work together. A lot of times people work in silos, and it's so much better when we work together in lots of different areas, but especially in palliative care. I did my master's thesis. It was called The Experience of Well-Being in the Midst of Advanced Cancer. And so I interviewed a number of people who I was intrigued in working with people who had advanced illness. And some people just really seemed to have this kind of inner strength or resilience, that they had sort of this positive outlook. And I couldn't really define what it was, but there was something special about some people. And so I interviewed people who identified themselves as having well-being. And it was really interesting what I found out, and it was such an honor for those people to spend time with me. And one of the key things was that they made choices. And I'm going to talk a lot in this presentation about choices and what can influence the decisions that you make. And so in those interviews, I found that people who have a limitation that they know about of when an illness might progress, they really made a lot of choices about where they spent their time, about the types of activities they did, about the types of people they spent time with, and the way that the things that they thought about and how they focused their mind. So really interesting for me, and quite an honor. So today we're wanting to do a few different learning objectives. And the first one is to understand changing ideas about palliative care. And there's some new language and some new things. One thing that's been really exciting in the last 5 days or so was their release of from Health Canada, a national palliative care, palliative approach framework for Canada. And what's really exciting is that the federal government is working with all of the provincial governments to really improve access to quality palliative care and care with a palliative approach. And I'll tell you about the differences between those two things. But there really is, especially in light of medical assistance in dying, there has been a renewed focus on palliative care, helping people to live comfortably and have a high quality of life, regardless of what the diagnosis is. So really exciting, positive directions that are happening. So we're going to talk about considering how decision-making and priorities can change when you get a diagnosis of a life-limiting illness. And I'll talk about what I mean by life-limiting illness too in a minute. Understand the steps of planning for your future. So that will be a bit about advanced care planning and talking with families. Learning about the resources that are available. One of my jobs is to develop and to collate, to bring together resources for healthcare clinicians. And what I'm hoping to help you with today is so that you understand when you're talking to a nurse or a doctor or a pharmacist or whoever, what resources they might be looking at. And that will help you to know what questions they're going to ask and what types of conversations you can be ready for. And then consider how you can have wellness in the midst of illness. So just a little blurb about why I love palliative care. This picture was taken by my daughter, who loves photography. She's 14. And near our house, there's a cemetery that's really old and lots. So you can see in the back of the picture, there's kind of a fuzzed out gravestone. And what I just loved about this last spring is that the whole thing was covered in these little purple flowers. Somebody online probably knows what they are. I don't. But I was just really struck by the beauty that can happen in the midst of difficulty. And probably many of you have had all sorts of different types of difficulty. Often when I meet patients and family or people with illness and their families and the people around them, I am often struck by the difficulties that they're going through, but then also the beauty that arises. And some people have said to me, how can you work in palliative care? So the traditional meaning of palliative care is care for people who are dying. And so people will often hear what I do, and they'll say, well, isn't that depressing? How can you work around death all the time? But I just absolutely love it. And the reason I do is because when you know that your time is going to be impacted by illness, when you're still feeling well or relatively well, you make different choices and you don't think as much about the trivial things. And I've always been somebody that has a difficult time with small talk. I really have a hard time with talking about kind of surface level things. I love talking about where people find meaning. I feel very honored to be part of the meaningful moments that happen when families gather around and just really appreciate their relationships and the people. And a lot of times I find lifelong conflicts just go away. People think, oh, I'm not going to hold this grudge anymore. It's ridiculous at this point in our lives. They really focus on what matters to you. And what I've learned from working with people who have life-threatening illnesses is that we all have time limitations. We never know when our life is going to be over, and we never know when our loved ones might not be with us anymore. And so, really, we should all be thinking about spending our time on what matters and on what's meaningful. Some of you may have seen that illustration where you take a glass jar, if you put all of the, and you have sand and you have large rocks and you have small rocks. If you put the sand in first, sometimes the large rocks and the smaller rocks won't fit. So what that's an illustration of is that the things that don't really matter can fill up your life. But if you do it the other way, where you put the big rocks in first, and then the smaller rocks, and then the sand, everything can fit. And that's what I've really learned from working with people, is that when you first prioritize things that really matter, you're much more balanced and have room for the things that are important to you. So, talking about what palliative or hospice care is, it's a philosophy rather than a place. So, I'm just having trouble, Marianne, seeing the notes that go with this. Do I need to change my view? Oh, there we are. Thanks. Notes. Okay, good. Thank you. So, not a place, it's a philosophy. So in the States, they talk a lot about hospice care and palliative care. They've come to be really similar words. In terms of locations, though, there are palliative care units that are part of acute care hospitals. And those are where somebody really needs intensive symptom management, and they might go there to work with palliative specialists to get their symptoms worked out and under control, and then they would go back home, or they may die in the unit. Hospice care is a little bit of, it's more of a place that people go that's got a home-like environment, so you wouldn't go there normally with unstable symptoms or unstable issues. It's more of a place where people aren't able to stay at home for various reasons, and so they'll go to a hospice care area. Something that happened over the last couple of years is that in BC there was a commitment by the government to increase hospice beds, to double them, and hospice spaces. So there was funding given to each health authority to increase, and it's a hospice bed is a different level of care and cost. So a lot of times they were put into residential care homes or long-term care facilities. So what it basically means is that there's dedicated places for people who aren't able to stay in their own home. And the intent is that that would be a home-like environment. But the philosophy of palliative or hospice care, I'll use palliative just because that's what I'm more comfortable with, but they're really quite interchangeable in terms of the philosophy. So there's a focus on quality of life, comfort, and living well. So it's distinguished from sort of a cure-based philosophy in that we work with people who have an illness that can't be cured. You might be able to have somebody live longer, but you can't cure it, like you can't take away the illness. So instead, we focus on living well throughout the entire journey. It's person and family centered. So what's really important is your values, your beliefs, and your priorities. And we really try and center all of the care and all of the planning and things around that. And it's team-based. Most healthcare does involve a healthcare team, but in palliative care even more so, because it's holistic, so it thinks about the whole person. Often you need many different care professionals. I'm going to talk a little bit about the different skills that people can bring specifically to Parkinson's, and the idea that care that focuses on quality of life and comfort and living well should be offered right from the time that you get a diagnosis. So traditionally, palliative care has been originally, like I said at the beginning, started near the end of life, whereas now we're talking about a palliative approach. And really, I mean, to the average person, the difference between palliative approach and palliative care doesn't really mean anything to you. I like to talk about supportive care. So if you think about the care that has been traditionally palliative care, it's focused on quality of life, living well, person and family centered, team, and this holistic idea that we're focusing on spiritual, emotional, physical, mental, all of those different types of wellness, not just on the physical. That's really true of any type of care, even if you're in a car accident and you're healthy otherwise. All of care should really be that way. So, palliative approach has been brought in. What it really means is adapting those principles that traditionally were just at end of life to all of care for people that have diagnoses. So that can include dementia, frailty, which is people just kind of getting older and more weak, respiratory conditions, heart failure, liver failure, kidney failure, multiple sclerosis, and Parkinson's. So it's anything that is incurable and progressive, and that's the definition of a life-limiting condition. Palliative care used to be a separate specialty, only offered near the end of life. Now what we're focusing on is trying to help people who work with folks like yourselves from the time of diagnosis to understand ways to help support the symptoms that you might have with medications and things like that and treatments, but also with other things that family members and non-professionals can do as well. So you may hear my pages turning because I've got a printed here as well, but if you hear sort of a fluttering, that's what it is. So Parkinson's is life-limiting in that it's incurable, it's progressive, and also affects all aspects of your life. And I'm sure those of you that are on our webinar that have Parkinson's can attest to the, even if you're not having any symptoms or very few, you can attest to that it affects all the aspects of your life. So what I want to talk about a bit now is how a diagnosis changes your life. So two things. One is recognizing that your time is limited or may be limited by an illness that you weren't thinking about before. And some people have said to me that when they have a life-limiting illness diagnosis, it's very difficult, of course. And part of it has been said to be a gift in that, like I said before, all of the non-important things sort of fall away and you really think about what matters to you and where you want to spend your time. So it can make a difference in decision making. So I think about a young lady who I spoke to a long time ago, who said, having this, she had terminal cancer, and she said, having this has been the best thing because my whole life I've watched my weight, and now I don't really care. So now I can eat ice cream every day, and I just love it because I've always not let myself. And she said, and I've been dreaming about these red cowboy boots my whole life. And, well, not my whole life, of course, but for a couple of years, I've been really wanting them. And I thought, oh, it's a waste of money. And so I bought them. So she wore those with pride. And a lot of people talk about having a bucket list and wanting to focus their time on trips and on doing different things. My husband took me and my family on a trip to New York and then to Italy and France a few years ago. And on the way home from that trip, I said, my bucket list is full. I said, I could die on a plane crash on the way home because I'm done. So I just felt really good about that I don't have regrets. And obviously, those things that are important to you are different for every person. So this is a diagram that we use in talking about advanced care planning. So advanced care planning is really thinking about what matters most, talking about it with those that are close to you, and then planning for future. And the focus of advanced care planning, terms that have been used in the past are things like advanced directive, thinking about power of attorney and all of that sort of thing. Some legislation has changed over time about who can make decisions for you when you're not able to make your own decisions and that sort of thing. But the main thing about advanced care planning, a couple of things. One is that anybody can do this. Anybody who's over 19, and actually I've done some of this with my teenagers, can talk about what they would want if they had a serious illness, if they weren't able to communicate anymore, and can talk with their family. So thinking, what would you like to know about your illness? What's important to you? What are you afraid of? What kind of medical care would you not want? So it's not thinking only about what often gets asked when you get sent to the hospital is, do you want to be resuscitated? Like, do you want CPR? That's actually kind of a different conversation. What this is thinking about is really when it drills down to the basics, what is important to you? So for example, what's important, this is kind of a shallow example, but what's important to me is food. I love food. And so it would be important to me if I couldn't communicate, would be just to say that even if I was at risk for choking, I would still want to eat. So that's something I've talked to my family about. Um, and another thing to think about is who would you trust to make medical decisions for you if you couldn't speak for yourself? And some of you may know that there's a list of what we call substitute decision makers. And I can provide that link. I don't think I have it in the presentation, but there's a list of an order that the BC government has decided if you couldn't communicate your wishes, they would, I think it's they would first go to your spouse, they would go to your parent and your kids, and there's a whole list, like uncle is in there and all these different people. So if you wanted to look at that list, if you want somebody who's different than that list, is you do need to make a legal representation agreement, because or else they will default to that list of people. So talking about what you've thought about, thinking about, well, who can answer the questions about my illness? Who do I need to talk to? Who needs to know your values and wishes? How will you start the conversation? We've got a lot of tools through the BC Centre for Palliative Care about ways to play games and ways to think about what's important to you and ways to communicate with your family members and that sort of thing. So what we've discovered, what has been found over researching over the last couple of years, is that originally with advanced care planning, there was a lot of focus on legal documents, making sure you had everything written down properly. But what we've found over time is that those documents are helpful, but only because it was part of a conversation, because you can't predict what things are going to be like for you, and you can't predict what might happen. Like I said, any of us could be in a car accident or have a sudden illness or something like that. You never know what's going to happen. And you can't always predict if this was the case, then I would not want. Because there's people who live with spinal cord injuries that they're on a respirator and they can't move anything, and yet they say they have a very high quality of life. Whereas we may imagine that and say, no, I wouldn't want to be alive. But sometimes you just don't know until you're there. So what has been found with all this advanced care planning is that talking about your values is what's important. And thinking about what's important to you, because that underlies all of the different conversations. And then planning. So recording your wishes, writing it down, and sharing your plan with those that are closest to you. And what we found in our family is that this is a very casual conversation, and it's part of a lot of our conversation because my husband's a pastor of a church, so he talks a lot with people who are dying in their families and plans funerals and things like that. And I do the work that I do, and so our kids who are 17 and 14 are around all of that. So we regularly at dinner time talk about who we want to have today. Actually, I was coming back from morning coffee with my husband, and he was telling me who he wanted to do his funeral. And my daughter has told me what she wants if she is in a major car accident and she's brain dead or what that sort of thing. So we just talk about it all the time. And it's just casual. And of course, that's not the same for every family, but there's different strategies that you can have to talk about this thing. The other thing is letting your family physician know what is important to you. So they do have a specific billing code, so that if you make an appointment with your family doctor and say, I just want to come in to talk about my advanced care plan, they can bill that. So it doesn't need to be part of another type of appointment. And I've talked with some family physicians that I've worked with in the past, and they said they would love it if people would make that specific appointment so they can really focus on it. They say that often what happens is people come in and it's part of another appointment, so it can't be as focused. So go ahead and make an appointment and just let them know what's important to you, because they will be the one that's consulted in the future. So every choice that we make in our lives is a balancing act. So I'm going to show this diagram a few different times. Like I said, it's not just about major choices about CPR, do not resuscitate. It's thinking about everything, how you spend your time, where do you want to live, who will care for you, how will you communicate if you are unable to communicate verbally? Are there some strategies that you can think about? One thing I wanted to talk about specifically is where you will live. And that's something to think about, benefits versus cost. and to talk as a family about, because it's not only a personal decision, it's a family decision. Because eventually, as I'm sure you've all thought about, eventually people with Parkinson's do need some help with their daily living. And if people are wanting to stay at home right till the end, it is a family commitment, and it is a commitment sometimes financially, and sometimes it impacts the family a fair bit. And some people love the idea of being able to give that gift to their family members, and so the benefit of caring for their family outweighs the cost that it might take, taking time from work or making it more of a priority. That can be considered a worthwhile thing to do. So just really thinking about what are the benefits versus the cost. Another one is about what tests and procedures you will have. So sometimes people who are nearer at the end of life, if they have an infection, for instance, we wouldn't always do a blood sample or a different type of sample to see where their infection was, because that might cause more harm. So the benefit of knowing where the infection is versus the cost of the pain of a test might not be worth it. So we do a lot of this cost versus benefits. And I'm going to talk in a little bit about some symptom management guidelines, and those are guidelines for healthcare professionals in BC. They all have access to them everywhere in the province. And this benefits versus cost diagram is throughout those documents, just to remind healthcare providers as well that when you're making decisions, you always think about what's the cost versus the benefit. So some possible issues in later Parkinson's, and these I'm sure you're aware of, different things. So looking at this list can be somewhat scary, I'm sure. I have a friend who was diagnosed with Parkinson's a few years ago, and her first reaction was just complete fear, because she works with a lot of people who have Parkinson's later on. And there can be a lot of things that can happen that make life really difficult. But the number one message is that, and this is even, I noticed the Parkinson Society tagline, is that you are not alone. These things can be scary. There's a lot of things in life that can be scary, but you're not alone. So often family members will be nearby. There's a lot of different ways that the healthcare professionals can help with all of these issues, and I'm going to talk through some of them. Also, there's a lot of organizations that are around. Parkinson Society, there's a family caregivers network, which is very helpful and supportive. And also there can be just friends and people that are close to you that can support. So the palliative approach, remembering that that's supportive care, holistic, team-based, focused on your priorities, how that can help. So these are all the team members, and some of you may have interacted with these different folks at different times. So physicians, there's specialists, as well as your family physician, pharmacists, physiotherapists. So I'm going to talk about some of these specific things. Two I wanted to mention, so home support workers are invaluable. So these are also called personal support workers or community health workers. And at some point, people with Parkinson's usually need help with bathing and getting dressed and that sort of thing. So that's something that home support workers are great at. There's publicly funded home support workers, and there's also a lot of private agencies. Some people choose private agencies because you're better able to be linked with the same worker to keep coming by, whereas with some of the publicly funded, it's a little bit more difficult because they're scheduling so many more hours, so it's more difficult to have the same one. So there's a lot of different options there. A case manager is really important. Many of you probably have encountered case managers, but they work for home and community care, community services, so they're publicly funded, and they will come out and do a financial assessment, because all of the publicly funded services for, it's called like long-term care, including going to an assisted living facility or a residential care facility, or residential care home, that sort of thing. It's based on a percentage of your income. So they are the ones that put you on a wait list and help organize all of that. Also, counselors and social workers can be very helpful. So just remembering that each member of the team brings a different piece. And the team, and where I sort of picture is that the person with Parkinson's is at the center of this kind of circle, and there's many, many people as part of a network supporting your loved ones as well as yourselves. And each person on the healthcare team brings a toolbox of knowledge and resources. So I talked about advanced care planning. There's many in the Hospice Society. There's a lot of different workshops for advanced care planning. There's resources everywhere. They have people, healthcare providers have skills of assessment. They have knowledge of equipment that can be helpful, knowledge of symptom management, and expertise in communication skills. So these symptom management guidelines that I previously mentioned, this was a project that took, I think, 2 years or so. They were released in November of 2017, so just last year. And what these were, and they're actually online, so you can find them and read them yourselves if you like. The audience is for healthcare professionals that are working with people with any life-limiting conditions. So we didn't do anything specific to specific illnesses. So you won't find specific interventions for Parkinson's or specific interventions for cancer. What these are is unrelated to specific illness. Many people still have the same types of symptoms. So they're based on the most up-to-date research. Every health authority in BC contributed to these. They are BC-wide. So everywhere you live, everywhere that people live in BC, your healthcare providers have access to these guidelines. There was considerations for the different care settings, so in home and acute care, in residential care homes, in rural, so areas where they're more isolated. With First Nations communities, we had input from Indigenous folks, giving us some really rich insight. And right now we're working on 2 new guidelines. One is for psychosocial care, so that's to think about grief and bereavement, spiritual health, spiritual wellness, emotional wellness, family dynamics, that kind of thing. And we're also working on what do you do when you can't manage the symptoms in the usual ways. So what part of those symptom guidelines includes an acronym that we help care providers to use when they're doing an assessment with you. So I'm going to use an example of fatigue. So many of you, I'm sure, many people with Parkinson's feel fatigued sometimes. So what we recommend, excuse me, for any symptom is that you keep a diary, because you've probably had this happen where you go to see your doctor about pain, for instance, and they'll say, well, when did you start experiencing this? And you think, oh, I don't know. And what makes it better? I don't know. So what can really help them to make an informed decision on what will help you is to have a really good assessment for a full picture of the symptoms. So it goes OPQRSTUV. Excuse me. So the O is for onset, and what that means is, when did this start? So when did you first start noticing that you were more tired than you used to be? Provoking and palliating, that's a phrase that a healthcare professional would know, but you might not. So palliating, the original meaning of the word means to lessen or to make it better. So you might say, well, what makes you more tired? What makes you less tired? So if you spend a day out Christmas shopping, likely when you get home, you'll find that you're extremely tired. So Christmas shopping would be provoking your fatigue. And then let's say having an afternoon nap might palliate your fatigue. So you might feel energized when you wake up. So that's the kind of thing you want to make note of there. Quality. So what this talks about is describing how you feel. So some people who have profound fatigue say that it's being bone weary, like into your bones tired. And it's a different kind of tired than they've had in the past. So the quality, what does it feel like? And for example, with pain, it's really important to describe the quality, because the type of pain that you have feels very different. For example, an aching, kind of gnawing pain in cancer can mean that it's bone pain, so they might have metastases to their bone. A sharp shooting, tingling, numbness type of pain can be a nerve pain. So those 2 types of pain need very different medication and interventions. So noticing the quality With Parkinson's, you may have contractures, so you're quite stiff and that sort of thing. So your quality of pain might be kind of aching or more of a dull sensation. The quality of fatigue, like I said, might be just bone weary, or it might be short-lived. Radiation, so that's not applicable to many symptoms, but what it is, if it's pain, this acronym was originally developed for pain. Radiation just means, does it travel anywhere else? Because if you have pain in one spot, sometimes, or if you, let's say in cancer, if you have a tumor in one spot, sometimes you might have pain somewhere else because the nerves are connected. So what we say is it radiates to a different part of your body. Severity, so you'll often get this, and you may have already had this. Nurses and doctors will say, can you rate your pain? How severe is it? From 0 to 10. That's very common. There's a scale that we use in palliative care all the time called the Edmonton Symptom Assessment Scale. It's called ESAS. We use it kind of ad nauseum. So if you're having pain, people will often say rate it from 0 to 10. So the severity, so you can rate any symptom like that. And sometimes, for some people, they find it a bit difficult, but if you're able to do that, it helps your care providers make decisions or support you in making decisions. Treatment, so this is what helps. So if you're profoundly fatigued and you find that if you meditate for 5 minutes a day, that treatment really makes a difference. So that's something that you found that helps. So that's an example. Understanding. So what is your understanding of what this means? For example, in Parkinson's, you may find that you get more fatigued as time goes on. So some people might say, well, I understand that my Parkinson's is actually getting worse because I'm more fatigued. So the symptom kind of scares me a bit because I see that things are changing, and that's my understanding of it. So it's important for you to make note of that. And also your values. How is this impacting the rest of your life, the rest of your family? So if you're so tired that you can't enjoy your grandchildren, for example, you might place benefits. There's a palliative care benefits program that when it was developed, you could only access if you had 6 months or less prognosis, which means your estimated time of life was 6 months more from now. That's changing a little bit. Those time limits are kind of changing. But anybody can call into their local home and community care office and say, I'm having some concerns. I'd really like to talk with someone about my needs as my illness progresses. And a home care nurse can come out and do an assessment. That would be the first step. So you can refer yourself, or your GP can refer you.
All right, so when we call in the, you said home and community care office or home health office, we're asking a care nurse to come in and do a home assessment as well as I guess like a personal or a personal assessment of what their needs are.
Yep. And the number would be under intake. So there, I'm sorry, I only know web resources. But if you look up in the intake for home and community care, there's an intake number for every region. Excuse me, for the health authorities.
Yeah, okay, and we have those numbers, so for everyone who's listening, we will be sending you all a follow-up email with some of the important links and resources in there, so you don't have to look around and search yourself.
Yeah, and it's nice to have that assessment done, like I said, before things are in crisis. You know, like if you think in the next couple months I might start to need a home support worker to come help me with a bath, the sooner the better, because that assessment can take a bit of time. So it's good to get on wait lists and things like that early on.
That's true. And so you mentioned this a little bit, and it kind of relates to accessing and then receiving palliative care, but where do most people receive palliative care? You talk about staying at home for longer. How do people receive these types of services typically?
So people, from surveys and things that have been done, most people prefer to stay at home until their death. And like I said, that's a commitment of family and friends or whoever, because there's a limit to how much public service is available. However, it depends on the region and it depends on the benefits and all that sort of thing. When my day several years ago, there was up to 4 hours of publicly funded service that people could receive at home. But to answer your question, many people in BC do die at home. Many people die in residential care. I would say that's probably the most common is residential care. A lot of people also die in acute care, and we know from research that most people would prefer not to die in acute care. So that's why this planning is really important ahead of time. Because usually when people end up in acute care, like the hospital, an emergency room, it's because there hasn't been planning ahead of time.
Okay.
So it's sort of like a crisis point, whereas it sometimes doesn't need to happen that way. So part of what we're trying to do at the center is really support care providers in every care setting, especially actually in long-term care, which is where a lot of people with Parkinson's may live. Is to support the nurses and care aides and doctors that work there to support people in that environment rather than transferring them to hospital.
Mm-hmm. Okay. And we have a question here from someone. If a person is deemed palliative, is the financial cost lower?
That is a good question. The financial cost is different. I don't know if it's lower or not. I'm not totally positive. I think it might be. But the case manager at the health units are the experts in that.
Okay, thank you. I think
Yeah,
that's
it's a different type of designation for the bed itself. Services, yeah.
I think that's all the questions for now, if you wanted to kind of continue on with your segment.
Okay. And it's funny because I thought, oh, I only have 30 slides. I'm going to be really fast, but of course I'm blabbing. So I'll try and sort of speed up a little bit. So I just pulled out some of the highlights of the symptom management guidelines, different ways that you can support your loved ones and yourself with the different symptoms. So with pain, in palliative care, we talk a lot about total pain. And what that means is areas of life that could be increasing your pain. For example, if somebody has pain from a fractured leg, and they're feeling really guilty that they were, I don't know, driving without a driver's license and that led to them breaking their leg, they will have more pain because of that guilt, in addition to the broken leg. So what this is really saying is pain isn't only physical. Pain is very much a total pain experience. So that's why it's important to pay attention to what else is going on in your life and to share that with your healthcare team. Lots of different things that you can do. Not only medication helps with pain. The goals of pain management are kind of in order here. So the first goal is for you to have a good night's sleep. My doctor always says to me that pretty much every problem start with the basics. Get good nutrition, get good sleep, and get exercise or activity. So pain control while at rest, pain control when active and ambulatory. So we all know that when you're in pain, you're not doing as much activity. So it's really important to try and take action early on when you first feel a pain, because it's a lot harder to control when it gets really bad. It's also important not to only take medication, but to try other things like relaxation, a little bit of exercise. Positioning can really help, the way that you're sitting, seat cushions, things like that. So medications for pain, when a physician's prescribing your pain, they're going to make decisions based on what you've told them in the O to V thing that I was asking you to keep a diary of. So they'll choose which medication to use based on how severe your pain is, because if your pain is a 10 out of 10, they're going to start with something stronger than if your pain is a 1 out of 10. Also the quality. So like I mentioned, if it's a shooting, numbing, numbness, tingling type of pain, that's a different medication than a gnawing, aching pain would be. The timing of when you take it is going to depend on the onset. So what causes it? What starts this pain? How long has it been going on for? Provoking and palliating. So remember, those are what makes it worse, what makes it better. So for example, you might have what they call a PRN. That means as needed. You'll usually have a regular medication dose and then a PRN, so as needed. Sometimes people will be totally fine until they try to stand up and walk. And so what often happens is people don't stand up and walk, they just sit still, which is not good for you, obviously. So what they might do is give you a really fast-acting medication as a PRN so that you take it and then a couple minutes later you walk. So that kind of thing. These are the rules that healthcare providers follow. So start low, go slow. By mouth is the best way to start. By the clock means a regular routine of pain medication works better than only as needed. And the route will depend on swallowing abilities. So as people progress with Parkinson's, often, you have difficulty swallowing. So you can still have just as effective pain control because you can change the route. So they can often, what we do is put, it's called a butterfly. It's a little, it's put in with a needle and then the needle is taken away, and a little cannula, which is like a little straw, stays under the skin, and then there's a little port on the top of the skin. So it goes into your fatty tissue. So it's called subcutaneous butterfly. So if you can't swallow, you can still have just as good of pain control with other routes. And watching for sedation or confusion. So I am going to talk quickly. Sorry, I'm just looking through my notes. Yes, I am. Sometimes when you initially start on medication for pain, you can feel a bit drowsy or confused. Sedation just means feeling kind of tired. Often those symptoms will go away after a couple of days. So if they don't, then you really need to pay attention to that. And then keeping your diary. So noticing what causes your pain, what makes it better, that sort of thing, and keeping a diary of that. So I talked about fatigue already. One illustration that I find is extremely helpful is the energy bank. So saving up and making an intentional withdrawal. So this is one of the key things about considering what depletes my energy and what increases my energy. So some people find, and actually physical activity is really important. They found in lots of research studies that sometimes when you're really fatigued, if you have too much rest, it actually makes your fatigue worse. So there's a lot of different types of gentle activity like Tai Chi, a little bit of dance, a little bit of movement, energy restoration activities. So thinking about what actually makes a deposit in my energy bank. So some people find meditation, listening to music, things that you enjoy, doing a craft can actually increase your energy. Plan for assistance. So knowing that, so let's say, for example, having a shower and getting dressed takes all your energy for the day. On your bath day, that is all you can do. So let's say that that's all you can do, but yet you know that your grandchildren are visiting in the afternoon. Maybe you don't want to deplete your whole energy bank before your grandchildren arrive by having a bath. So what you could do is have a home care worker come and help you have a bath so that it doesn't take as much energy, and then you'll have more in that bank for when your grandchildren come. So this is really thinking about what's important to you. The other thing is adapting expectations. Let's say if you used to be the person who cooks the Christmas dinner and has 20 people at your house, maybe you don't need to be the one doing that anymore. And you can still contribute in some way, but adapting your expectations that we need to think about, what's this going to be like now? Adapting your environment and routines. One of the most helpful people, healthcare providers, is an occupational therapist, and they can be accessed through the home care office as well. And they also have outpatient clinics. Things like having a reacher, having a raised toilet seat, and they can also talk about how to save your energy up. For example, when you're having a shower, using a terry cloth robe, so that instead of using a towel that you have to move across your whole body, you can just have a terry cloth robe that absorbs the water, so it saves a little bit of energy. So with fatigue especially, I find with each activity you're considering, think to yourself, what is this going to cost me from my energy bank, and is it worth it to me? Is this a meaningful enough activity that it's worth it? Now, constipation, with decreased activity, with many of your medications, especially some of your pain medications, you will be constipated. That's almost a given. So the key is to prevent, because it's so much easier to prevent. Every time you get prescribed a new medication, ask, is it going to have an impact on my bowels, and how do I need to make changes or things about that? So just the same as with any little kid, lots of water, lots of fiber, and activity makes a very big difference. When you're moving around, it just helps everything to move. Another thing that people don't always think about is positioning and privacy for bowel movements. I can tell you that a bedpan is the enemy of a good bowel movement. It's so hard to imagine having a bowel movement in a bed with other people in the hospital room. So really important to think about how can you have privacy and how can you be sitting up straight, because that really helps. And then pain control if needed. Sometimes people need to have a whole routine about how they're going to have a good bowel movement. Sometimes you need to have one of those quick-acting pain controls because it hurts to sit up for that length of time. You might think about having a padded toilet seat or a raised toilet seat, that sort of thing. So difficulty swallowing, like I said, there's different routes for medications, speech-language pathologist, or there can be multiple different care providers that can be certified to do a swallowing assessment. They give you different types of foods and see how they go down. There's also scopes that you can have to see how your swallowing is. Modifying the textures, just sort of changing your expectations around eating time. Sometimes it needs to be quieter. Some people who may have a lot of activity around them or watch TV while they're eating, sometimes you just need to slow it down. Positioning sitting up. And if people aren't, sometimes people with Parkinson's end up having a tube feed and can't take anything by mouth. But you really need to think about how can we still involve this person? How can I still be involved in important social gatherings? Now, oral hygiene really helps. I'm just noticing I'm going to be out of time soon. So having a decreased appetite, think about what will give you the biggest bang for your buck. So adding protein powder, adding greens powders to smoothies or purees or things like that. A lot of people hate Ensure or Boost. Sometimes it helps if you change the temperature. So you might freeze an Ensure Boost and thaw it out a little bit and eat it like ice cream because you expect ice cream to be cold. So it doesn't taste overly sweet like it does when you drink it. And just remembering that as any life-limiting illness progresses, you can expect to have some decreased appetite. And that's because your body doesn't need as much energy because it's kind of slowing down and shutting down. So sometimes that's hard for family because a lot of the times the way that we show love is through providing food. So just thinking about that. So I wanted to mention quickly the difference between delirium and dementia. A lot of times somebody can suddenly be really confused and their family thinks, oh, they're getting older, this is a sign of dementia, and they just kind of accept it and work with it. But if something starts really quickly and it fluctuates during the time of day, so let's say in the afternoon somebody makes complete sense, but in the night they don't. And it's the key thing is that it starts really quickly. That can be caused by infection, by all sorts of things. So it's really important to see the doctor if something like that is happening. If you notice any difference in someone's confusion. And just a mention of the psychosocial, the difficulty of having this type of illness, all sorts of things, being afraid, having grief. People often have grief before before somebody actually is dying. You can have grief on different types of losses, so losing independence, that sort of thing. And focusing on, I've seen so many people where their physical body is shutting down, but they can have healing and wellness, and they can be extremely well in every aspect except physical. So really thinking about that. I'm just going to end with this picture. This is, it's called Hope. So if you can see it, you probably can't, but basically this figure is in darkness. She's got a blindfold on. She's got a harp with one string, and she's really feeling discouraged and seeing that there's only one string left to hang on to, and her life is kind of difficult, very difficult. But in the top left, there's a little tiny white dot, and on the picture, when you look closely, it's actually a little star. And that star is shining light right onto her face. So what this is showing is that no matter how dark things feel, there's always hope. So it's thinking about what brings you hope, what brings you meaning, what can bring that feeling of positivity. And I have found that often knowing that you're not alone, these are the types of services that there is. And that people are here as a network to support you and to support family.